All right, let's dive right in. Today, we are stepping into a simulated high-stakes consultant oral exam for general surgery. And the topic? It's acute mesenteric ischemia, one of the most lethal, time-sensitive emergencies a surgeon will ever face.
So, picture this. You're in the exam room. All those years of training, all leading up to this exact moment. Across from you sits the examiner, and they're about to present a case. Your job is to manage a life-or-death emergency, all while under some serious pressure. This is based on a real exam scenario, so let's see how a top candidate would handle it.
And there it is, the opening line. Every single word here is a massive clue. A 70-year-old man, atrial fibrillation, severe abdominal pain. The clock starts right now. The examiner is looking at you, waiting.
So, here's how we're going to tackle this case. We'll start with the initial approach, move to the diagnosis, figure out the management plan, go inside the OR, and then talk about how to really nail this case and secure that pass. Let's break down every single step.
Okay, first things first. You can't treat what you haven't assessed. What the examiner wants to see right from the get-go is a safe, logical, and really structured approach. How you start this whole thing really sets the tone for the rest of the exam.
The first question sounds simple, doesn't it? But it's really a test of your whole process. So let's hear how the candidate responds.
Okay, first, I'm going to take a really thorough history. I need to get the details on the pain, its onset, how it's progressed, where it radiates. I'll ask about any nausea, vomiting, or changes in his bowel habits, and given his atrial fibrillation, a detailed drug history, especially for anticoagulants, is absolutely crucial. Same goes for his smoking history. Then, I'll wrap up with a full systemic review to make sure I'm not missing anything else.
You see the strategy there? The candidate isn't just firing off random questions. They're building a story, a narrative of the illness, starting with that main complaint and just expanding outwards. This shows the examiner that you're methodical, you're safe, and you're not going to miss something critical.
The examiner nods and gives you a bit more info. The patient says the pain is dull, progressive, and it's around his belly button. He's had some nausea, vomiting, and diarrhea. And then comes the follow-up. What will you do next?
Right. Next, I'll move on to a focused physical examination. I'll start with the patient's general appearance. Does he look distressed? Then a full set of vitals. After that, I'll examine the abdomen for any tenderness, guarding, rigidity, or masses. And to finish, a digital rectal exam is a must to check for any blood.
Okay, the examiner reports back. He's got some diffuse abdominal tenderness and distension. Rectal exam is positive for blood. His vitals are holding steady for now. So we've got our initial data. Now comes the really important part, starting to put these puzzle pieces together.
This is such a core question. The examiner is testing how broad your knowledge is, and more importantly, if you can prioritize based on what you're seeing.
Well, given his age, the history of atrial fibrillation, and the severe pain, my #1 differential diagnosis is acute mesenteric ischemia. But I'm also going to keep other causes of an acute abdomen in mind, like IBD, diverticulitis, a perforated viscus, or even a bowel obstruction. Did you catch that? Putting AMI right at the top of the list, that's the key.
So, you've laid out the possibilities. Now, how are you going to narrow it down? The examiner is looking for a plan that's logical, fast, and makes sense.
Okay, my immediate plan is to admit the patient, make him NPO, and get IV fluids running right away. I'm going to order a whole set of labs, CBC, renal function, electrolytes, amylase, coags, and, most importantly, a lactic acid and an arterial blood gas. I'll also get an ECG and some baseline chest and abdominal x-rays.
The examiner gives you the results, and this is where the siren should be going off in your head. His white blood cell count is sky high at 19,000. His arterial blood gas is showing a metabolic acidosis, and his lactic acid is elevated. His ECG? It just confirms the atrial fibrillation. These three things together are a massive, massive red flag.
And this just perfectly captures the classic textbook presentation. The patient is telling you he's in agony, but when you first examine his abdomen, it might not be rock hard or show those classic signs of peritonitis. This mismatch, this pain out of proportion, is practically a giveaway for acute mesenteric ischemia.
The picture is getting so much clearer now. The examiner wants you to commit, put a name to it, and tell them exactly how you're going to prove it.
My provisional diagnosis is mesenteric vascular thrombosis, and it's most likely an embolic event from his atrial fibrillation. The gold standard, and the test I am ordering right now to confirm this, is a CT angiogram of the abdomen. You hear that? It's confident, it's correct, and it's direct. Perfect answer.
Okay, We've got our diagnosis. From this point on, it is a full-on race against the clock. The management plan has to be aggressive, it has to be thorough, and it has to happen immediately.
The examiner confirms it. The CT angiogram shows a vascular obstruction right at the superior mesenteric artery. This is it. This is the point of no return. The patient's bowel is literally dying, and every single minute counts.
The pressure is on. This isn't just about the surgery. It's about getting a critically ill patient stable enough for that surgery. So what's the complete management plan?
My immediate actions are happening all at once. I'm continuing aggressive fluid resuscitation, starting systemic anticoagulation with an IV heparin drip, and closely monitoring and correcting his acidosis. I'll get a central line and a Foley catheter in, start broad-spectrum IV antibiotics, and, most importantly, prepare for an emergency laparotomy.
The patient is stabilized and on the way to the OR. Now we shift gears from medical management to the surgical strategy. A laparotomy is when we surgically open the abdomen, and the decisions we make in there are going to decide the patient's fate. The examiner wants a quick but complete summary of your surgical plan. What are the absolute critical steps once you've made that first incision? As soon as I'm in the abdomen, my very first step is to assess the viability of the entire bowel. I'm going to resect any intestine that is clearly dead and non-viable. If the remaining ends of the bowel look healthy, I'll perform an anastomosis, basically rejoining the bowel to restore continuity. And here's the critical part. I will absolutely plan for a second-look laparotomy in 24 to 48 hours to come back and recheck any parts of the bowel I was worried about. The surgery's over. The patient is in recovery, but the exam is not done. Post-operative care is just as vital for survival, and it's your chance to show you understand the entire disease process, from start to finish.
This is such a great final question. You've handled the acute crisis, but the thing that caused it, the atrial fibrillation, is still there. So how do you stop this from ever happening again?
Postoperatively, I'll continue the heparin infusion. Once the patient is stable and we're sure no more surgery is needed, I'll start him on warfarin. I will overlap the two drugs until his INR, which is how we measure blood clotting, is in that therapeutic target range of 2 to 3. After that, this patient is going to need lifelong warfarin therapy. So here it is, the high-yield takeaway. If you remember one thing, it's this triad. A patient with a history of atrial fibrillation who comes in with severe abdominal pain and whose labs show a metabolic acidosis, you have to think mesenteric ischemia. It has to be at the very top of your list. Suspecting it early is the absolute key to survival.
And really, that's the ultimate test, isn't it? It's not just about knowing the facts from a textbook. It's about applying them systematically when you're under extreme pressure. This case proves that a structured, logical approach isn't just about passing an exam. It's about saving a life. So the question you have to ask yourself is, when that pager goes off at 3 a.m., are you ready?